antiparasitic activity or removal of bacteria and toxins from the blood. The circulatory system brings blood to the liver from the stomach, the intestines, the spleen, and the pancreas. The liver has many functions, such as metabolic, secretory or secretion, vascular, and storage. Table 38.4 on page 837 gives you much more detail about the functions of the liver. Everything that it's doing, it's filtering blood, it's a reservoir for the blood. It's the synthesis of prothrombin for blood clotting, fat metabolism. Many people that are going in for surgeries, they'll be told that they have a fatty liver or something like that, and you need to decrease the amount of fat around your liver before we can have surgery. You can do it. A lot of people that have gastric bypass or gastric sleeve, they're put on a fat or liver fat reducing diet, which is basically liquid. You're going on a liquid diet, it'll be high protein, things like that. And it decreases the fat around the liver faster than a typical diet. Bilirubin is the pigment derived from the breakdown of hemoglobin. Once in the blood, it binds to albumin. There are two types of bilirubin: conjugated, which is water soluble, and an unconjugated, which is insoluble in water. The biliary tract consists of the gallbladder and ducts that connect the liver, gallbladder, and the duodenum. The gallbladder is located below the liver, and its function is to concentrate and store bile. A lot of times you'll get the question for some people if they have gallstones or they have cholecystitis, which is inflammation of the gallbladder. They'll ask, do I really need the gallbladder? You don't, that's the going question. You don't really need it, but it helps. I don't know if you just have to have it. I mean, there are many people that don't have one and function just fine, so. The pancreas is a long, slender gland lying behind the stomach, and in the front of the first and second lumbar vertebrae. It's made up of the head, body, and tail, and consists of lobes and lobules. It has exocrine and endocrine functions. The exocrine function contributes to digestion through production and release of enzymes. The endocrine function occurs in the aisles of Langerhans, where different cells release insulin, amylin, glucagon, somatostatin, and pancreatic polypeptides. And when you're going through all of your assessment for your patients, you have to consider age, you have to consider their gender, their ethnicity, because not everything's going to affect everybody the same way. So there are different questions that you're going to have to be asking. The major thing that you have to consider is age, because the older you get, your body, the functions slow down or they don't function the way they're supposed to. Diet, alcohol intake, and weight, just to name a few, change the way your bodies react to different things. And we as health professionals, like I said, must take these into account when you're dealing with an elderly person, because almost everything will have a more in-depth effect on them, or the symptoms can mimic something else. With the GI system and age, taste buds decrease in number. The sense of smell lessens. There's less saliva, which leads to dry mouth or xerostoma. Smooth muscle weakens and leads to delayed emptying of the esophagus. GI motility decreases. There's a higher prevalence of constipation. The liver decreases in size, unless there are other factors that are playing a role in causing enlargement. But through all of that they're going through, their functions should stay the same. They should still be making the same enzymes, proteins, breaking down, all of that. It just may do it a little differently than everybody else. Some of the enzyme changes decrease the liver's ability to metabolize drugs and hormones. Table 38.5 on page 840 has a lot of information to read over about medications and the processes of age and the GI system. 38.6 gives you surgeries of the GI systems, what they are, basically the definitions for them. So if you hear one of those terms, you'll know it was removal of this or surgery on this. 38.7 on page 841 gives some of the assessment questions for the GI system. When you're obtaining the health history of a patient, you want to ask some of these questions. You want to look and see if do any of those apply to your patient. There are many things or factors that can affect your GI system, causing distress, such as stress in itself, activity or exercise, your sleep rest patterns, your elimination pattern, nutrition, etc. You'll want to know about allergies, especially if they might have a test performed with IV contrast. You want to know, are they allergic to shellfish? Do they have any issues with betadine, iodine, anything like that? You also want to know if someone is taking something that may upset their stomach, like ibuprofen. If they've been taking it long term, it can cause stomach issues like pain or ulcers. If someone's complaining of diarrhea that just came on or has been ongoing for a couple of days, what would you ask them? What's something that you could ask them? Anyone?
Have you taken anything for that?
Have you taken anything to treat the diarrhea? What else?
Have you eaten?
What have you eaten?
Have you traveled outside of the United States?
There you go. That's the one we're looking for. You want to know if they've been outside the United States recently. A lot of people that go to Mexico will get what they call Montezuma's revenge, which is basically really bad diarrhea. And you are basically going to clean your whole system out, no matter what you want to do or don't want to do. So you're going to need to be close to a bathroom for a long time. After you get the subjective data, you're going to want to be looking for objective. So what do you see as the nurse? You're going to inspect, you're going to auscultate, percuss, and then palpate. We also want to remember to always auscultate before the percussion or the palpation, because we don't want to stir up any sounds that wouldn't have been there in the beginning. It's just like when you were learning how to do your head to toe when you were in skills lab. The findings for a normal physical assessment of GI system are given in table 38.9 on page 846. And then also table 38.10 outlines some of the abnormalities. So, I mean, that's going to be kind of a broad spectrum, because what may be normal for one person may not be abnormal for somebody else. I mean, that could be their baseline. So, and it's in the abnormal field, but that's what they stay at. So you also have to take that into consideration. There are several diagnostic studies that can be performed on the GI system. Table 38.11 goes from page 847 to 850, and it breaks them down into categories: radiology, endoscopy, blood studies, liver biopsy, and fecal tests. When you look over the tables, make sure you're looking at the nursing responsibilities, because you want to know what your role is as the nurse for that patient. You want to know what you need to be looking for, what you need to talk to them about. Oh, you want to be looking at all these things. You want to take everything into consideration, because looking at your patient may give you indication that something is not right or something's not going the way that it should be, and maybe they've taken a turn for the worse, even if it was after a simple colonoscopy or something. If your patient is getting a colonoscopy, They shouldn't take blood thinners. If at all possible, your blood thinner should be stopped 2 weeks prior to the colonoscopy. That may not be possible for everyone because they have the therapy that they're on, but at least 48 hours prior. The doctor's going to give them all of that. They'll get that at their pre-surgery appointment. You also want to know what tests require sedation, because some people will need to have somebody drive them and stay with them and take them home after the test, because you will not be allowed to drive yourself. If you do drive yourself in for the appointment, most likely they're going to admit you because you're going to have to stay until sedation wears off. Because we can't put a sedated person in a cab and say, hey, hope you make it home. It's not going to happen. That's a liability. If you have somebody that's having a test that has IV contrast, you want to be sure and educate them on the need to flush their system by drinking plenty of water over the next few days. Because we don't want the IV contrast to build up in their system. So we want to constantly be flushing that out. And that's with any test that you have, especially if it's one with IV dyes. If they have issues with the colonoscopy or with an EGD, most likely they're going to be NPO after midnight with all of the diagnostic studies, except for maybe your fecal tests, things like that. But if they're NPO, you'll have those patients that are going to try to bribe you, smile, get you to give them anything. My mouth is just so dry, I need something. And the most you can give them are those little swabs to moisten the inside of their mouth, because they can't have anything because you don't want anything to interfere with the test result. If they do have EGDs or colonoscopies, sometimes you'll get a set of standing orders that will tell you once the procedure's been done, they can go back to whatever diet they were on originally. If they're having an EGD, most likely they were NPO or on clear liquids or something like that prior to. So you're not going to put them on a general diet because that's going to create a whole other set of issues. Now, a lot of times you'll have to gauge it by your patient. What does your patient look like after they have this test? Are they, with it? Are they coming out of sedation okay? Before you give them anything to drink, has their gag reflex returned? Because we don't want to give them something and then they choke on it and aspirate. So you have to look for all of that. You're going to be inspecting your patients. You're going to be assessing for all of these things. You may not be in a specialty lab or like GI lab or anything like that, but being on the med-surg floor, you're going to see all of this. You're going to see all these patients. You have to take all these things into consideration at all times. You're always assessing. Let's see. And that's all I was supposed to tell y'all. I'm trying to think. Make sure if they're getting EGDs, colonoscopies, anything like that, that you have consent signed. Any test that you're getting, pretty much you need to have a consent signed. So make sure you have that on the chart. If it's a patient that's getting blood or they're going down for a colonoscopy, something that may cause them to lose a lot of blood, even if they don't get blood while they're there, we have them sign a blood consent just in case, unless there's a religious reason. And typically you'll know that ahead of time, especially if you did their admission assessment.
I know you get blood banded before you go to surgery. So does that mean that they take blood from you and go ahead and type and screen you to see what kind of blood you are? So if you have to get blood during surgery, they already know what to give you. So
Yep.
they've already drawn that blood and everything, and it's
Yep.
down before they even go to surgery.
Yeah, if you get blood banded, they've already typed and screened, run cross matches to see what types of blood they can give you. They do that as a precaution. Not necessarily saying that you're going to get blood, but just in case, we need to make sure we have the type of blood you need here. Like some people will need irradiated blood. If they're a neutropenic patient, they're usually going to need irradiated blood. And typically, it's not here in Lawton. It'll have to come from Oklahoma City. So it takes a little while to get here. So they want to know that prior to.
So in that case, if the blood's not available, given that they may not need it anyways, will they postpone the surgery to make sure the blood is available?
Well, that's why they want to do everything before the type and screen and all that, because if you do need irradiated blood, then it only delays it maybe an hour or two at most, and they can, put a rush on it if they have to. If it's emergency surgery or something like that, you're not going to know prior to. You're just going to do the best you can with what you have. Let's see. On space, and it was something I was supposed to tell y'all, and I'm trying to think of what it is. But I don't remember. So let's take a quick break. Maybe it'll come to me, and then we'll continue. So maybe 10-minute break, and I'll figure out whatever it was I was supposed to tell you.